This presentation is about troubleshooting complete dentures. So many times an older person will come to your office, or it could be a younger person as well with dentures, and they have a complaint about their dentures. You may want to jump to making a completely new set of dentures, but that would be a big mistake. You first need to figure out what is wrong with their dentures and whether or not that can be corrected by modifying those dentures versus making new dentures. So the subtitle here, you can't fix a problem until you know the cause. So when are we going to troubleshoot? Well, the obvious one that all of you are well versed in is the insertion of a new prosthesis. But you also may want to evaluate a denture complaint that the patient comes in with. You may want to determine if replacement is unnecessary. Some problems can be fixed with a reline, with an adjustment, and some problems can't. Okay? And sometimes when there's a reason that replacement isn't practical, so maybe the most ideal solution would be to replace a denture, but because of finances, the ability of the patient to cooperate, or time, we can't actually fabricate new appliances. Okay. Is there always a solution? No. Some patients just can't wear dentures. They bring in a bag of dentures, and you know that many people have tried and nobody seems to be able to help them. That may be indicative that you can't help them. Now, going back to my original premise, if you can't figure out what the problem is, you can't solve it. So if you look at the dentures that they say they can't wear and you cannot find some technical discrepancy, something that you know you would do differently, then what you're doing is just rolling the dice, hoping that your set is somehow going to solve this problem that you have no idea what problem you're trying to solve. So it's useful to learn the denture history. How well are they wearing these dentures? How long have they been wearing them? How new are they? Were these made on the day of extractions and never gone back for a reline or replacement? Is this something that was made recently, or something that they wore without a problem for many years, and then suddenly things started to deteriorate? So there's a lot of different causes, so always get the history so that you're clear on what's going on. The other issue that one has to look at when you're looking at an older person who's having trouble with dentures is that sometimes the dentures they present with don't meet our textbook standard, but if they're comfortable with them and they like them and they manage with them, but just something is sore, that would be a reason that you may want to just alleviate the soreness so as to not create a large change, because a lot of people can't adapt to that large change at a certain point in their life. Okay? And again, the psychological issues, read the patient, listen to the history. So what kinds of complaints do we usually see? Most common, pain and discomfort, poor retention or movement. They report the denture moves all around when they're trying to chew or when they're trying to speak. Aesthetic dissatisfaction, and that's one that you can't fix with a reline, but find out what it is so that you can say, if they don't like the position of the teeth and you see that the teeth are in an ideal position, you may not be able to promise anything different there. Usually we can change aesthetics easier than anything else, though. Speech issues or gagging, listen to what they're saying, because we're going to approach things differently according to what the complaint is. So with respect to the complaint of pain and discomfort, usually if somebody complains of soreness after repeated adjustments, you will look at a denture that's been carved down, perhaps by someone who's not being as careful about responding to the entire history. They may report cheek biting. We're going to talk about each of these separately. So one of the things that is often overlooked is that thick flange in the retrozygomatic area can cause soreness where it doesn't look like a denture is touching at all. So you're going to take a look at the maxillary part of the denture and put PIP paste there and see whether or not that coronoid process is actually rubbing against the tuberosity. That can cause the denture to displace, and it can cause pain on the tissue, and it's a part of the tissue that you wouldn't normally expect to see any soreness because there's no denture base adjacent to that tissue. Are the patients clenching or bruxing? You can usually tell bruxing from the look of the teeth, that it's wear facets or worn down totally. There may be inadequate freeway space. This is not typical for a denture that somebody's been wearing for a while, but it may be one that somebody pulls out and says, I can't wear this, it's new, but I never could wear it because of the rest position and phonetics were wrong. And are there errors in occlusion? And we're going to talk a lot about errors of occlusion in just a moment. For simple errors of occlusion, you can carefully remount and analyze the occlusion. It can be difficult sometimes to look in somebody's mouth and see where the first contact is, but if you can carefully remount it, you can study it on an articulator and get that view, that throat's eye view of how the teeth are touching. With respect to looseness as well as pain, you want to check that the centric position is correct. You want even, stable contacts on both sides at the same time, and we don't want any interference on excursions that's focused on one side, not the other, without balance. So you can check that with articulating paper. It can be hard to tell. A way that is a little bit more involved to perform, but if you're seeing things on articulating paper that suggest all the teeth are in contact, but that's not what you're hearing based on the symptoms from the patient, then remount, as I said, is one way, but another alternative is something called a Coble balancer. This is something that in the past we used to do what we called Gothic arch tracings, but in simple terms, what's involved here is a platform is compounded, so it's temporary, across the mandible, and a dial is embedded with compound on the palate, and this dial is variable. So as you turn it, the pin is going to rise and fall. And what's done is the denture is placed, the pin is brought out enough so that the denture does not touch anywhere, and the patient closes. You're trying to put the pin in the center point of the denture so that when you hit it in only one spot, it is a balanced spot because it's at the center. Then you are going to gradually turn the pin until you first get a contact. And where that contact is first seen should be everywhere at the same time. And usually you'll discover that it's not everywhere at the same time. So that initial contact is on a particular tooth or on a particular side. When that happens, the denture will tip if you're hitting one side before the other and compress the tissues. So when you're looking at the occlusion without the Coble balancer in, it looks like the teeth touch all at the same time. But what's happened is there's a compression where you hit first and then all the teeth touch, or the denture tips and then all the teeth touch. And it's that very tipping and compression that can be the source of the pain. And so what you're going to do is you'll lower that pin till you first see a contact. You'll mark that contact, adjust it, put the denture back in, have them close on that pin again. You may have to turn the pin in a little bit so they close a little bit more deeply. But you're going to keep doing that and adjusting where the contacts are until the pin touches and all the teeth touch on both sides at the same time. Now you balance the dentures. And thus the term Coble balancer. It's a balancer. I imagine it was invented by somebody named Coble. And this is most effective